Good morning. This is Thursday, April 23rd, and Gary and I are back again with some real topical questions I found that have been in the social media, because this is really what your patients are hearing, and you might get questioned on this. So I have a few questions. First of all, Gary, there was a recent public study that came out of the VA that suggested that hydroxychloroquine was not effective in treatment of COVID. What are your comments on that?
So I think that we're not seeing hydroxychloroquine be the drug we hoped it would be. And we're learning some things. There's probably about 5 studies now, maybe 5 or 7 studies, showing that hydroxychloroquine doesn't not have an impact with mild or severe disease. And so it's not the drug we hoped it to be. And we're also learning about some toxicities with it. So the IDSA, the Infectious Disease Society of America, developed guidelines for treatment of coronavirus. And our guidelines are, basically everything is unknown. Now the NIH last Tuesday also came out with some guidelines, and their guidelines talk a little bit more about the data we know and we don't know. And what we know about hydroxychloroquine, there's been about 86 confirmed deaths related to chloroquine's toxicity, and most of that's cardiac toxicity. We also know that hydroxychloroquine and azithromycin, that early study from France, is remarkably toxic in a certain cohort of patients. So the NIH guidelines state that everything you do in a therapeutic manner beyond the standard of care should be done in a research study. And they actually caution hydroxychloroquine with azithromycin must be done in a research setting because of safety. So hydroxychloroquine isn't the drug we hoped it would be, either is Kaletra, the HIV drug. And a lot of other drugs are being used right now in trials, and we just have to study it well.
Okay, thanks. Also, Gary, there was a report just recently that in retrospect, there were 2 COVID fatalities from early February, far sooner than we thought. What does that mean? Does that mean there's a large cohort of asymptomatic patients out there?
So those are 2 cases from Santa Clara County. So in Santa Clara County, on autopsy, 2 patients' lung tissue tested positive for coronavirus. So these are respiratory associated fatalities that happened in Santa Clara County in February, and that predates the first cases they had. That's not surprising. So when China had when they declared their first cohort of patients that were infected, that was about December 8th, they were probably dealing with this in late October. So when we confirmed the first cases, there have probably been a couple other cases before that. So you're probably not going to pick up the first case, you're going to be on the front end of the first wave. Now in Sonoma County, we were interesting because when the cruise ship came here, 100 people got off that cruise ship, and 2 of them came to the hospital with an infection. Of those 2 patients who were infected, we were waiting to see if the other 100 people would have any disease, and we didn't see it. We never saw secondary and tertiary cases from that cohort of patients. And then if you compare that with our respiratory clinic data, early on our respiratory clinic had testing capability because we were working with public health and the shared lab. When we loosened up our screening and we were actually testing almost everyone with respiratory disease, 90% of patients in a respiratory clinic got tested. That means that's kind of a prevalent study. How are we doing in our community with COVID-19? Early on, about 4.5% of patients were positive in our respiratory clinic. And then later on, a couple weeks later, 3%, 3.3%, now it's 2.7%. So if there was a subset of patients with asymptomatic disease, we would be seeing these mushrooms and these out pockets and these little epidemics happening in the community. We're just not seeing that. So I think that in Santa Clara County, with the density of the population, and maybe those 2 cases represented 200 cases, but in Sonoma County, we didn't see that from the cruise ship, and we haven't seen a mushroom of events here. So I think we don't have a cohort of asymptomatic people walking around, and that certainly is everyone's fear. Everyone is so afraid of that. Going to Walgreens, going to Costco, people next to you, But I think washing our hands, wearing masks, I think that's been very important steps.
Okay. Next one, which is really topical for our providers, is yesterday in Governor Newsom's press conference. He made the suggestions that we start resuming elective high priority surgeries. What are some of the issues we should think about before we jump into that?
Well, first of all, I think Governor Newsom's right. I think he's right that we have to start thinking about this recovery phase. And I know that Peter's working on a committee that is about recovering. How do we get back to work safely, sensibly, without starting up another epidemic? And so I think Governor Newsom's speaking to that, and I think it's the right time for that. Are we over our epidemic? We really don't know. It's going to last for a long time, and some areas may still be the peak, other areas may be beyond the peak. But I think now's the time for us to think about how do we get patients in who have been on pause and are waiting for the testing and the surgery and the chemo and the PET scan that they need, because we can't postpone care forever for our patients. So getting them in a sensible way is important. And in the surgery, I'll use the example of the surgery patients. If someone needs surgery and we postpone that and it has to happen somewhat urgently, then that patient needs to be swabbed. We need to know if that patient is in this asymptomatic, pre-symptomatic period, and so we don't expose the rest of the hospital staff.
Right.
In the operating room, those are positive pressure rooms, not negative pressure rooms. So if someone has coronavirus, you're going to blow it through the OR. So it's very important we know if that patient's positive.
Right.
And that means, what is our testing capability? Do we have enough? Is the lab ready for a surge of patients who are going to be asymptomatically tested? And that's the conversations happening right now with Shared Lab. They're bumping up their testing capability, as is our hospitals trying to do that as well. But there's also data from China about the post-op patients. So China has this cohort of patients that went through surgery and then developed coronavirus.
Okay.
So either they were incubating coronavirus, had surgery, and then it manifests, or maybe they picked it up in the hospital nosocomially. But those patients had a high mortality. So patients in the post-operative setting, if they develop coronavirus infection, are going to have a tough time of surviving. So we want to make sure that testing asymptomatic people, it's important to not expose other staff, other patients in surgery care centers, but we also want to make sure that patients are not incubating coronavirus, then go into a coronavirus illness in the post-op setting, because survival is going to be very, very difficult.
So it sounds like testing is going to be critical, and I understand we continue to have some shortages in that realm, the ability to test.
Yeah, there's a nationwide shortage, not just of testing capability, but of swabs. And one of the big things right now is reagents. We just don't have enough reagents to run the tests. Some places have the machine, but they don't have the reagents. And so bringing that all together for this surge of testing is going to be very important. And I do think this is the time to bring people sensibly in, but we need to make sure that when patients come back to our care centers and back to surgery and back to chemo and back to PET scans, that one, they're not going to pick up coronavirus here, they're not going to spread it to our staff are not going to spread it to them, and we don't see a secondary surge of the epidemic.
Good. Great. Well, I hope that's been helpful for you, and we'll say goodbye for now. Thanks.